So good afternoon, everyone. I'm Dr. Samuel Collins. I'm the UVA Division of Outreach and Echo Research Director. The Division of Outreach is here at University of Virginia, and it's part of the Department of Psychiatry and Neurobehavioral Sciences. Outreach works to improve access to education and care addressing mental health and substance use disorders through cultural and community-driven approaches and targeted provider education, much like this. Dr. Larry Merkel is our professor of psychiatry and neurobehavioral sciences, and he serves as our medical director. We're grateful for collaboration and support today from the Virginia Neonatal and Perinatal Collaborative, Postpartum Support Virginia, and the Blue Ridge Poison Center. They all helped us distribute this series, and I'll make mention of what they do and what they're up to a little bit more. But first, let me explain what is an echo if this is your first time joining us. Simply put, it's a virtual means of delivering subject matter expertise to clinicians and relevant community members. By doing this online, we're able to democratize knowledge. We're able to create cohorts that otherwise wouldn't be logistically feasible. And then here at UVA, we applied the model to both small didactic learning communities and then also in larger webinar formats like what we're doing today. So a quick note about these folks that are supporting us and also vital, important contributors to this issue and supporting the dyad here in the Commonwealth. Postpartum Support Virginia, they're a nonprofit organization established to educate families, healthcare providers, and community members about perinatal mood and anxiety disorders. They provide free and direct services, including year-round warm line, virtual and in-person social support groups, and a peer mentor program and care coordination program. You can learn more about them on the web at postpartumva.org. Next up, noting that we're also supported by, and they're a great resource, the Virginia Neonatal and Perinatal Collaborative, or the VNPC. They're the statewide perinatal quality collaborative working to improve outcomes for mothers and babies across the Commonwealth. They work to ensure that every mother has the best possible perinatal care and every infant is cared for in Virginia, and so that they have the best possible start to life through evidence-based, data-driven, and collaborative approaches. Through these various quality improvement projects, the VNPC creates connection and advocacy working with clinical and community partners. You can learn more about the VNPC at govnpc.org. And then lastly, the Blue Ridge Poison Center. If you are a clinical practitioner or researcher in the state, they are a fantastic resource. They're staffed by nurses and doctors specially trained to handle exposures to all sorts of poisons. This includes everything from medicines and plants and household products and industrial chemicals, even snake bites, carbon monoxide, and more. So they have experts available by phone for immediate, confidential, and important thing, free treatment advice 24 hours a day, every single day. They also answer non-emergency questions about poisons and poison safety. Their medical toxicologists provide clinical consultation for healthcare providers, and they also perform research and teach health professionals about managing poison patients. And they have a public education department. Many of their staff members and faculty members at UVA that also participate have been previous ECHO panelists as well. Some housekeeping about ECHOs. So ECHOs are based around collaborative exchange with frequent questions and answers. So there'll be significant time allotted for Q&A today, but please note also, this isn't like grand rounds. Over the course of the ECHO, please post any observations, resources, and or questions that you have in the chat, and we'll be monitoring and noting those and either saving them for the Q&A or addressing them or discussing them in the chat. So again, live time as they come to you, feel free to share those. Logistically, for APPs, nurses, and physicians, we do have CME credit available. So there'll be a slide at the end of the presentation, and the CME info will also be included in the follow-up email that'll be sent to today's participants. The contact info for the CME office will be present, so please follow up with them rather than Drs. Holland, Kellum, Zanelli, or me. That's outside of our purview, but their information is there. Please note too that this session is being recorded, and we plan on sending out the recording subsequently after each one of these sessions. Also, do note that this is part 1 of 3 in this series. So next week, same time, same place, same Zoom link. We will, on August 24th at 4 p.m., be considering the Eat, Sleep, Console model, in addition to discussing medication management and then some best practices around discharge. And then on Thursday, August 31st at 4 p.m., we'll wrap up the series. And this is new for this year. We're expanding. If you're coming back for our NOWS series from last year, we'll be taking a deeper dive into breastfeeding, and this includes patient follow-up and then how to measure and create an environment for the best possible outcomes. So lastly, let me introduce a few folks that will be on our panel over these next 3 series. Dr. Liza Holland is an associate professor of pediatrics and a board-certified pediatric hospitalist here at University of Virginia. Dr. Santina Zanelli is a UVA professor of pediatrics and a neonatologist, and Dr. Ann Kellums is a professor of pediatrics and director of UVA breastfeeding medicine. So Drs. Holland and Zanelli work together on UVA's NAS protocol, and all 3 of them as physicians, I personally know, are advocates for family-centered strategies for NOWS care from the ambulatory setting all the way to the NICU. I'm grateful for their work in training resident physicians and fellows here at UVA and for being a repeat outreach ECHO panelist. They make my job as an epidemiologist and public health researcher pretty easy. And I'm also thankful for the 3 of their contributions to our recent DEA project. So we have 8 hours here at UVA that's free of charge on opioid use and substance use disorder education. And that's free, especially if your license is coming up. So many of you are here from that series that we ran in June and July. I'll drop a link in the chat so that you can take advantage of that free education if you are a prescriber in the Commonwealth. With that said, I'll turn it over to Dr. Zanelli. Thanks, everyone.
Thank you so much, and good afternoon, everyone. Thank you for part 1 of this 3-part webinar series on neonatal opioid withdrawal syndrome, or NOWS. There you go. So this is part 1, and as Samuel already mentioned, this is a 3-part series. Today we're going to focus on the epidemiology of neonatal opioid withdrawal syndrome in the United States and in Virginia, and how we can identify these babies, make a diagnosis, and then we'll talk about a little bit about supporting the diet, but this will be also expanded upon in the next 2 webinars. Next week, Dr. Holland will focus on the Eat, Sleep, Console model to monitor and approach management for these babies. And then on the 31st, Dr. Kellums will talk about breastfeeding, also with supporting these families through that. So when we think about neonatal opioid withdrawal syndrome, it's important to remember and recognize that this does not just start with the birth of the baby, and ideally it's a continuum of care for these families that can start pre-pregnancy, but at a minimum during pregnancy. We'll talk a little bit about that a little bit later. But today we're going to focus on the neonatal aspect of it. And neonatal opioid withdrawal syndrome is, as you know, caused by the abrupt discontinuation of chronic fetal exposures to opioids used or abused by the mother during pregnancy. Opioids are low molecular weight molecules that are liposoluble and cross the placenta very, very easily, so can cause disease in the baby once it's abruptly discontinued with birth. Often other drugs are implicated and can complicate the pictures for these babies. And I just wanted to mention that you may see in the literature NOWS referred to as neonatal abstinence syndrome, or NAS. I think it's now recommended to really use the term neonatal opioid withdrawal syndrome to be more specific and to think of NOWS as a subset of NAS, but you probably will see both being mentioned in the literature. I just wanted to make a note that opioids that you use at time of delivery to manage maternal pain for the delivery itself does not cause NOWS. So what are we looking at? These are graphs showing the increase in the incidence of opioid withdrawal syndrome over the last decades. And as you can see, 1 baby every 30 minutes was born with NOWS in 2009. It peaked in 2018 to 1 in every 15 minutes. And it seems to be leveling down more recently to 1 every 24 minutes. And these babies have very significant increase in their needs. As you can imagine, they have, and this is 2020 data, increased length of stay compared to babies that do not have NOWS, 9 days versus 2 days. And also that's associated, of course, with higher healthcare cost, almost $8,000 versus $1,000 for those that do not experience NOWS. This is happening in the backdrop of a very significant ongoing opioid epidemic in the United States. Since 2000, more than 1 million people in the US have died from drug overdoses, and most of them are due to opioids. Fentanyl and other synthetic opioids are driving the crisis in recent years, and the COVID-19 pandemic certainly has exacerbated the crisis. And this is just an example of what's happened between 2019 in the light blue and 2020 in the darker blue. You can see overall increase of drug overdose death by 30% since the start of the pandemic, and most of it is due to opioids, specifically synthetic opioids such as fentanyl. This is just another way to look at the same data, just showing, a steady increase in drug overdose death in the United States with a similar picture in Virginia, and then this really significant increase with the start of the opioid pandemic. And as this graph shows here, mostly, driven by fentanyl here, by synthetic opioids here in the red, and most of it is fentanyl. So men are more likely to die from prescription overdose than women. However, overdoses related to opioids are increasing at faster pace in women. So women are catching up to men. And from a medical standpoint, women are twice as likely to be prescribed opioids compared to men. So of course, this is translated in an increase of pregnancy that are affected by the epidemic, with opioid-related diagnosis documented delivery increasing by 131% between 2010 and 2017. The most recent data that we have, which is from the 2019 NNWR report, is that about 6.6% of pregnancy report use of prescription opioid, and amongst those, 21% access the opioid from someone other than the healthcare professional or use it for reasons other than prescribed. A whole third of these women really would like to decrease or cut down their use of opioids during pregnancy. So it's really prime period to help them get help or into a program. And the good news is that most of them, about 70%, are receiving counseling on the impact of opioids during pregnancy and how it could in fact affect the baby. This is just a graphic representation. With this increase of opioid prescription, we have an increase in opioid use disorder in pregnancy, which impacts the babies, and with this really rapid increase in withdrawal in babies as well. This is the most recent data that I could find. This is from JAMA in 2021 of the national picture for neonatal opioid withdrawal syndrome in the top 2 maps, and the maternal opioid related diagnosis in the bottom 2 maps, which are obviously related to each other. The maps on the left represent the incidence per 1,000 births on the top map, and then per 1,000 deliveries for the bottom map. And on the right, you just see the percent increase between 2010 and 2017. So when we look at the incidence itself, the highest, you can see there's a wide variation within the United States, with the highest incidence being in West Virginia, with an incidence of 53.5, when the average for the United States is 7.3. Virginia is just below the national average. And you can see how states have increased in these short 7 years, with a vast increase in most states, with the fastest increase again being in West Virginia, with a 283% increase. And it matches very well, as you would imagine, what's happening to the mothers. However, interestingly, the highest change for the mothers between these 7 years was in Arizona. There's some good news, or maybe semi-good news, that we are starting to gather from opioid prescription with all the education that's been ongoing. This is a recent NHANES survey looking at 13,000 women. You can see there's a decrease in opioid prescription during pregnancy by almost 2% between 2004 and 2018, which was statistically significant. When we look at long-term prescription, we also see a trend towards decrease, but that's not statistically significant. This survey also identified some predictors of who is more likely to be prescribed opioids and who's more likely to be prescribed long-term opioids. Obviously, poor health status, older age was identified as risk factors, but also some health disparities were highlighted, with non-Hispanic white being more likely to be prescribed opioids and public health insurance being another risk factor. I wanted to show this slide to just show you how opioid use in pregnancy compares to other substances in women. This is another national inpatient sample with a cross-sectional analysis of more than 33 million deliveries, with an overall rate of substance use disorder of 1.5% for this sample, where the opioid use disorders are, this is overall in the light blue here on the top, overall substance disorders with really rapid increase since 2010. Opioids are in blue, so you can see increase in 2010 and seems to be maybe tapering. And what's increasing more rapidly is THC as things become more legalized in many states now. When we look at other drugs, they're all combined here in the gray line is pretty stable. Looking again now specifically at opioid withdrawal syndrome, this is the United States map in 2009. You can see again state variation, but the rates were pretty low. Overall was 2.9, with Virginia being just below the national average, and the highest rate at in 2000 being in Vermont. Step forward to 2019, and everything is much darker, with everybody experiencing significant increases. With West Virginia being, again, the state with the highest rates of the neonatal opioid withdrawal syndrome. The most recent Virginia map from the VDH website is 2020, and it's shown here. And you can see, again, there is variation within the state in terms of incidence, with the highest risk, highest hit areas being Southwest Virginia, Central Virginia, Northern Virginia, and the rate was 5.7 for 2020. You can see here, things seem to be fairly stable in terms of incidence, although we do have concerns that maybe this is a difference in reporting or diagnosing the babies, and Dr. Holland will talk a bit more about that next week. One thing I also wanted to mention, we are mandated to report NOWS cases in Virginia since the end of 2017. We have 30 days to report these cases, and we do estimate about 75% of these cases are captured. And here what you can see also is that boys are more affected than girls. The last thing I wanted to mention regarding epidemiology of neonatal opioid withdrawal syndrome is the difference between rural, suburban areas and urban areas. So again, on the left here, you have the babies with the neonatal opioid withdrawal syndrome. On the right, opioid use disorder. And you can see we've seen an increase everywhere. But since 2020, then there's a more rapid increase in rural, suburban areas in the blue circle compared to urban areas in the orange triangles. So let's move on to a case to illustrate some of the rest of our discussion. So this is baby S. This baby was born at 39 weeks by uncomplicated vaginal delivery to a 22-year-old mother who began prenatal care at 18 weeks, so late. She, at that time, disclosed using oxycontin 4 to 5 times daily for chronic back pain after a fall from a horse. She agreed to referral to a methadone program and was converted to methadone 80 milligrams per day. So you know this baby's at risk for opioid withdrawal. So what are you going to look for in the baby? How are you going to make the diagnosis? How long should this baby be monitored in the hospital? And is there a role for toxicology screening? When we think about approach to care for these families and the babies, we want to be sure we are systematically identifying infants at risk with no bias, that we have a standardized management approach. And the goal there really is to prevent complications such as full weight gain and dehydration, painful diaper rashes that can make the care complicated, and seizures, which are uncommon but can happen. And also, and very importantly, you want to support families so that they can be successful together. So that does take collaboration and partnership between multiple teams in the hospital and outside the hospital. families that know what to expect and what is expected of them, and families that understand the goals of outpatient follow-up. So we're not going to address everything with this part one, but this will be addressed with the course of the 3-part series. So from a clinical standpoint, neuro-opioid withdrawal syndrome is a generalized multi-system disorder that involves predominantly the central nervous system, the autonomic nervous system, and gastrointestinal system. It has highly variable presentation, I will discuss more, and it can be severe and intense, as you probably all know. It's a clinical diagnosis with toxicology confirmation. And in 2020, there's been a publication that was offering this definition of neuro-opioid withdrawal syndrome, which I think is very helpful and maybe will help better understand what we're looking at in terms of epidemiology. And what's really highlighted here is that a baby should receive a diagnosis of NOWS, even if they do not need treatment with morphine, for example. And you can make the diagnosis if the baby meets these 2 criteria. One, the baby had in utero exposure to opioids, so there's context there. And 2, the baby has clinical signs that are consistent with substance withdrawal. And you need to have at least 2 of the following signs. So excessive crying, poor sleep, tremors, particularly if they're undisturbed, hypertonia, increased muscle tone, and GI dysfunction. So if you have both in utero exposure to opioids and 2 of these signs, then the baby meets the diagnosis of NOWS, and in Virginia should be reported to VDH so that we can keep track of what's happening. And maybe what we're seeing with the decrease in reported incidents is that babies that don't require morphine maybe are not reported. It's unclear. So this is just a more in-depth review of all the signs and symptoms these babies can experience. From a central nervous system standpoint, so hypertonia is very common, and disturbed tremors are very characteristics. They can have exaggerated Moro irritability, high-pitched crying, decreased sleep, and then seizures are uncommon. I have never seen a baby having seizures, but in the literature reported to be between 2 and 11%. Autonomic nervous system signs and symptoms include sweating, low-grade fever, frequent yawning and sneezing, nasal stuffiness and flaring, tachypnea. And then GI system can be very problematic to handle with feeding difficulties, vomiting, losing watery stools that can cause very painful diaper rash, which then make treatment even more difficult, and poor weight gain, which is really something you're trying to prevent by monitoring these babies. There's some difference in the clinical phenotype that babies that are on methadone versus buprenorphine do experience. Babies on methadone tend to have more tremors, tend to have more hyperactive, more reflex hypertonia, and the overall withdrawal syndrome tends to be more severe than those babies exposed to buprenorphine, where there's more nasal stuffiness, sneezing, and loose stools. And we know why these babies are experiencing these symptoms, because with the abrupt discontinuation of opioid with the birth and removal of the placenta, the chronic stimulation of multiple receptors is impacted, and you have changes in neurotransmitter release that explains the symptoms. So for example, you have decrease in serotonin, which will lead to the sleep disturbances. You have increase in noradrenaline, which is the hyperthermia, tremors, tachycardia. Corticotropin increase is the stress, hyperphagia. Dopamine decrease will lead to irritability, anxiety. Acetylcholine increases the diarrhea, all the GI symptoms, and sneezing, yawning, and sweating. The difficulty, though, is that other drugs that moms may be taking, such as tricyclic antidepressants or SSRIs, SNRIs, can lead similar neurotransmitter changes. And so you do have to have a good history of maternal medication to really make an informed decision and have a better picture of what's happening to the baby. Other helpful things is that symptoms don't happen at the same time for these different drugs, and we'll talk about that more in a little bit. There are risk factors that increases the risk for the baby to develop neuro-opioid withdrawal symptoms. One of them is male gender. This is a graph from the babies enrolled in the Tennessee Medicaid program between 2009 and 2011. And you can see that the odds ratio of developing neuro-opioid withdrawal syndrome in boys is increased 1.18, and they also have an increased risk of needing medication, as you can see here. Other risk factors from the baby standpoint increase a higher birth weight and higher gestational age. And is that if you're premature, you're going to have decreased rate of exposure because transmission of opioid increases as gestation increases. So those preterm babies don't have as much exposure. So we do not see as much issues in our preterm babies, and we see that in NICU all the time. They also have immature kidneys and liver, so they are going to clear these drugs slower. So they have a made taper after birth. They have decreased fat tissues, which decrease drug accumulation, especially for methadone, and their receptors are just not as sensitive because they're immature. Pharmacogenetic factors can also influence the risk of a baby to develop opioid withdrawal syndrome. For example, if you have this variant for the cytochrome P450 variant, that will increase your risk of developing symptoms and requiring medication. From the mom standpoint, risk factors include the type of opioids, so duration, and also the type. If it's buprenorphine, the risk to the baby is slightly lower. The timing of drug usage, obviously, and whether or not there's other substances that are co-exposure. And if there are co-exposure, that does increase the risk to the baby by almost 50%, 30-60% on average, especially benzodiazepines, gabapentin, which we're seeing a really huge increase recently, and tobacco. This is what we know really as a summary of risk factors in terms of what's going to increase the risk to the baby that's exposed to the same meds, and that's going to have variable presentation. So, being term in a larger birth weight, drug use, and some of these polymorphisms definitely increase the risk. I just wanted to show this slide of a recent survey that looked at 38 million deliveries, and again, just to talk a little bit more about co-exposure. And when we look at opioids here, highlighted in the red box, you can see that co-exposure are very common. 62% of women that are on opioids have co-exposures, and the most common co-exposure is cannabis and tobacco. If we look at opioids as a co-exposure itself, you can see it's commonly associated with women that are taking amphetamines, cocaine, and sedatives. So co-exposures are very common. This is an important table that's really helpful to keep in mind when we think and try to sort out what may be causing the baby's symptoms. And as you can see, mom was taking heroin. The baby's going to have onset of symptoms fairly early in the first 48 hours. A range up to 80% of babies can be affected, and symptoms usually tend to taper within a week to 10 days. If you're on methadone or buprenorphine, you can see a delay in onset of symptoms, usually not in the first day, but 36, 48 hours. And this can actually be delayed till after discharge from the hospital. So, providers in the outpatient world should be aware that symptoms can be happening later than this usual time frame that's listed here. And you can see the difference in frequency of symptoms between methadone and buprenorphine, with most babies on methadone experiencing symptoms up to 94% versus up to about 70% for buprenorphine. And the key here is that those symptoms can be very prolonged. And in fact, there can be subacute signs of withdrawal, in these cases, 4 months in these babies. Compare that to non-opioids. So the key thing to remember for all of these different medication, SSRI, antidepressants, amphetamines, and inhalants, the symptoms are usually early. Less than 50% of babies are affected, and they're usually short-lived, less than a week. So that's going to help you really sort out what you're looking at and what medication regimen may work best for your baby if you're fitting the usual non-pharmacological treatment. So there is a recent publication from the American Academy of Pediatrics published in 2020 that's really provided new guidance on how long we should consider keeping these babies in the hospital. And they were very careful to use the word consider, recognizing that we have significant knowledge gap on how we want to balance monitoring the hospital and separation from the family. So the recommendation that is currently there for us is that the baby is exposed to immediate release opioids. You should monitor the baby in the hospital for 3 days, regardless whether there are symptoms, right? Buprenorphine and sustained release opioids 4 to 7 days, and methadone 5 to 7 days. So those are really important things that we can give ancillary guidance to these mothers before birth, so they can know exactly what to expect after the baby's born. In the same guideline from the American Academy of Pediatrics, they have a nice table helping us sort out what's an immediate release, sustained release, and maintenance opioids. Again, remembering that synthetic opiates cross the placental more easily than some synthetic opiates, and if there's co-exposure, it's even more likely that it's going to cross the placenta and cause trouble. So with this in mind, this is kind of the length of stay currently in the United States here on the left, and in Virginia on the right. You can see, as I mentioned, that, and then on the blue here at the bottom, you have babies that don't have neoopioid syndrome. So babies now obviously have longer length of stay from 2 days to now 9 days. So it's been decreasing. And this is largely due, in fact, to the fact that we are using new ways to monitor and manage the babies' sleep console, which Dr. Holland will go into more detail next week. I'll just talk very briefly about it in the next slide. And you can see we're very similar in Virginia in terms of length of stay as well. Things that are going to change how long babies need to be in the hospital are whether or not mom had co-exposures that will increase length of stay in general, what type of agent. So if it's methadone, it can be more prolonged, and how the baby's managed. If you use the sleep console approach, that decreases length of stay significantly. And there's also health disparities that are known here with the longer length of stay for Black and Hispanic newborns that obviously we need to be aware of and try to address as best as we can. I wanted to talk a little bit about sleep console approaches because there's this recent cluster randomized control trial just published in June this year, really confirming that it's a really safe approach to monitor and manage these babies. And again, Dr. Holland will go into more detail next week, but we had multiple studies previously showing that sleep console decreased length of stay safely, but this trial showed that you go down from almost 15 days to 8.2 days, and you don't have more seizures, you don't have more ER visit, your urgent care visit, hospitalization, and you don't have more non-accident trauma, no more deaths. So safe way to care for the babies. And then just briefly again, it's really a way to focus on the functional impact of withdrawal on the baby. So can the baby eat? Can the baby feed? Can the baby console? And if the baby doesn't have functional impact, then the baby is starting withdrawal symptoms as well. So it's a holistic approach that shifts really the focus from medical to family-centered care. So again, if everything is good, the baby is considered to start withdrawal symptoms as well, and you're going to just monitor in the hospital per the recent AAP guideline. If there's any single no, that's when you activate your multidisciplinary team and decide what's best to do for the baby. So this will be discussed in detail next week by Dr. Holland. So make sure to log in next week. So do these baby require toxicology screening? As I mentioned already, NOWS is a clinical diagnosis, but drug screening is helpful to identify exactly the type of substance used or abused by the mother, and it can be helpful to confirm rule out use of other illicit substances. So what you're going to do is twofold. You're going to review the maternal urine drug results and then set drug screen on the baby. These are the matrices that we typically use for babies. Urine is attractive because it's inexpensive and you get really quick turnaround. However, it has many drawbacks because of a short detection window, about 24 to 48 hours, although for chronic THC use, you're going to see it much longer. And then you often miss that initial sample babies, most of them pee in a delivery, so you miss the first window. So most centers do not use urine, and most centers use Meconium or cord. Both will provide a long detection window from about 20 weeks gestation onward, and both are non-invasive collection. Meconium is time intensive with regards to collection. You have to collect Meconium until transitional stools, which can be complicated. The baby has a medical condition that delays passage of Meconium or had Meconium passage in utero, and there can be contamination with urine. So a lot of urine now have transitioned to sending cord screen because it also has a very big logistic advantage. You can just send the cord right away. Although if the baby is transferred somewhere else, you may not have that option, and so you may still need to collect Meconium. Both are very good in terms of detection window, but they will not reflect periods of abstinence close to delivery. So they, you have to keep that in mind as well and get a good history from the mom. I wanted to show this interesting paper that was just published in July this year, looking at how often the drug screen that we send are positive. And this is for Meconium drug screen. And you can see that about 50% of them are positive in 2020, which is an increase a little bit from 2015. And I wanted to show this because, again, we're seeing less opioid positivity and more positive for amphetamines and THC, cannabis, in recent years, which is consistent with the national data that we've seen that the opioid use is decreasing in mothers, and maybe now it's decreasing in babies as well. So let's go back to our case. The maternal drug screen there was positive for methadone and oxycodone, and the core drug screen was positive for methadone and oxy. So we knew mom was in the methadone program, but we did not know about oxycodone use. So when you have this, it's not consistent with your history. So we go back and talk to mom. We need some more history taking. And what we talked to her, she revealed that she continues to have back pain and had some leftover oxycodone tablets that she started to take close to delivery to relieve her pain morning and night. I did not mention that to our counselors at the methadone clinic. Does this change your plans? It doesn't really change how long you need to monitor the baby because the baby was on methadone, that's longer acting opioids, but it may explain why this baby had earlier symptoms than what you would have imagined with just methadone alone. So here we would still recommend to monitor the baby for 5 to 7 days. I'm going to switch gear for the last few minutes to talk a little bit about family considerations, as it's a really, really important part of caring for these babies and their families. Again, I've shown this before. It's really a continuum. It takes everyone from prenatal to postnatal to hospital providers to, outpatient providers for the family and the children to really get to success with these families. And we do have a pamphlet that we have developed that we are hoping our obstetric providers and PFM providers can give these families to really let them, give them guidance on what to expect after delivery, and what's, to really help understand what we're going to be looking at. We are going to revise that a little bit and see if we can get this restarted. But the main talking point prenatally are really to emphasize that they are key partners, most important partners, central partners in the care of their babies, that we will really promote rooming in with mom or the care provider if mom is, in jail, for example, because this has been shown to lower rates of medication use and shorter hospital stays. And so therefore, we try not to go to the NICU unless it's medically necessary to really promote these co-regulatory care of the dyad. It's a good time to discuss and encourage breastfeeding as appropriate. Dr. Collins will talk more about that on the 31st of August, and then discuss what they can do, things that they're going to be able to do to help their baby so they can be prepared. And then importantly, let them know that we're going to need to monitor for X number of days based on what they're taking. But that can be shocking, especially if the baby is doing well and doesn't have symptoms, that we're monitoring the baby for, say, 3-5 days to look for withdrawal. When we care for these families, it's important to try to practice compassionate care and remember that drug addiction is a disease of the brain. It's not a moral failure. And reflect on our personal attitudes toward this mother with substance use disorders, because our attitude and stigma can have a profound negative impact on recovery and care or visitation to the hospital if they feel judged. Important to have a team that's really trained, trauma-informed, and that can help this family in a positive fashion. Formula therapy with this alliance with these families important can be difficult, as we all know, but it's important to really optimize outcome. One thing to consider always, and that can be tricky, is privacy. Sometimes we have moms that have not disclosed their use to their partners or their families, so really making sure that we understand where things are, and so that we can, as much as possible, respect that. And recognize that it's not always possible, but really engage your social worker and other team members to help address needs. We know that the hospital environment is both a source of support and tension for these mothers that try to exert their autonomy in the care of their baby. But again, keeping babies with mothers whenever possible really helps both mom and baby. And really, they don't need to be medicalized unless there's an actual medical need at all. So you don't need pulse ox, you don't need anything like that. This was a really nice paper that encouraged people to look at in more details, look at mother's perspective with regards to experience with NOWS. So again, feeling of internal external stigma impacts a mother's self-efficacy negatively. They have their own feeling of shame already, at least to have confidence. But if they have disinterested, judgmental caregivers that are in their care team, that can lead to more stress and even less confidence. These moms, a lot of them have history of abuse and trauma, and that can affect their feeding choices and bonding. Sexual abuse history may lead to issues with breastfeeding. So again, trauma-informed care here is important. If you had a baby that was removed previously, they may be anxious about this new baby. And they have their own recovery and visits that they need to juggle, so that can make the care of the baby emotionally and logistically challenging. But having a baby is really a prime time for really promoting a path to recovery, because these moms really usually have a lot of motivation at that time to continue to strive for recovery. So it's a good time to try to get services in place to get them moving forward. And this is just a very brief case to illustrate some of these key points. This is a baby born at 40 weeks to a 30-year-old mother, late to prenatal care, as you can see, polysubstance use, exposure, tobacco, fentanyl, heroin. Mom had other medical issues, including depression, and did need to receive some Butex, Atrax, and Ativan prior to delivery because of obvious withdrawal symptoms. Baby did require a brief NICU admission for respiratory distress, but that's subsequently transferred to the PIC ward for further care. Social work was on board right away and consulted CPS in the beginning. From a baby standpoint, baby was monitored initially with non-pharmacological support, quickly required morphine initially as needed, then scheduled. Then clonidine needed to be added, and he required that for about a month, and then was discharged home on clonidine with a planned taper outpatient. Cord screen was applied for codeine, morphine, and hydromorphone, and he was formula fed because of polysubstance use history. But I wanted to highlight here with this case sort of a different perspective, different team. The medical team's concerned that mom really wasn't at the bed, had prolonged absences from the bedside and wasn't present in baby's care as much as we would like her to, and was difficult to reach at the time. The mom's perspective was that, we as a medical team were not consistent with how we were assessing the severity of the symptoms for the baby, particularly relating to environmental variables. And she felt judged and reported that she didn't feel that she was treated fairly. Actually, recently took care of a mom in the NICU. Baby had serious medical issue that had a tattoo on her neck that says, judge me not. And I felt that was very powerful, because they do feel judged when they visit, and sometimes that's a barrier to visiting. She was anxious about discharge and the baby's progress, but felt that it would be a good transition and was looking forward to discharge. And this is a good case to highlight how social work and CPS working together can really get you to really great outcomes. So the social worker really allowed this mom to have space to share her concerns, and really was working with CPS closely to ensure support for the family after discharge, and that all these services were in place. And, you can see from this note that was written that obviously for this case, we had significant risk factors and concerns, right? Polysubstance use, late to prenatal care. Those are significant concerns that we all have when we care for babies like that. But, there are some many strengths that were important to recognize at the medical team. One, mom was very forthcoming with her substance use, and was really seeking support to help progress her need. And they were very identified many family support, and transportation was there, which is another key thing for follow-up afterwards. And CPS in this case determined that discharge home to mom was appropriate, really requested from our team to have clear communication of what we expected from mom in terms of being in the hospital caring for the baby, was actively working with mother, initiating services, and was planning a same-day visit in her home. So even in these type of cases where we have many concerns because of the polysubstance use, and things like late prenatal care, working together, engaging all these services, we can get to good outcome. And in this baby, subsequently, mom did follow up well. There were some concerns with clonidine wean afterwards, but things were in place, and it was successful. So this is where I am going to stop. And again, next week and the week after, we're going to talk more about this, but to summarize what we've reviewed so far. NOWS is a common complication of in utero opioid exposure. It's a multi-system disorder that can be severe and prolonged. It's a clinical diagnosis, and toxicology screening is helpful to confirm diagnosis and identify co-exposures. The care of these families is complicated, requires really teamwork and thoughtful approach. It should be comprehensive, non-judgmental, focusing on strengthening the caregiver-child relationship, engaging social work and community as much as possible. So again, this is just the summary of the next 2 webinars. On the 24th, again, we'll be talking more about eSleep Consult. This will be Dr. Holland. She'll review that model of care and how we decide when medication is indicated, and review hospital discharge and follow-up needs. And then Dr. Gillums on the 31st will focus on breastfeeding, again, how we can support these families as much as we can. And this is just the CME information for this session. And we'll be happy to answer any questions if there are any.
And I think we don't have too many folks. So if you want to come off mute and ask your question, that's fine. Or feel free to post in the chat as well. And the CME info will go out in the follow-up email.
I have a question. This is Karen Fairchild from Neonatology. So the physiology of pregnancy, the hormonal changes, and then the postpartum period, do we know how that affects substance use disorder? I'm just wondering if some of these moms are higher risk for postpartum depression or relapse and that kind of thing.
Yeah, that's a really good question. I don't know if Eliza or Anna the more precise data, but they definitely are increased risk for postpartum mood disorders. I just don't know the actual numbers.
Yeah, I don't know the actual numbers either, but there's clearly a high degree of comorbidities with substance use and addiction. And so and any of those comorbidities, whether there be mood disorder in the form of anxiety or depression, bipolar disorder, put you at higher risk of PMAD or perinatal mood and anxiety disorders. Sorry, I missed the word there. And so I consider them to be extremely high risk. And in addition, the stress of staying in the hospital longer and or having to support their baby, whether it's pharmacologically or non-pharmacologically, in the days after birth, and then also the concerns about stigma and families where some of the family members and support people may or may not know what is going on. I think they need all kinds of support, and if you have the resources for counseling and doing the postpartum depression screening at every opportunity, I think that would be extremely important.
I guess I'd like to just say there is a little bit of an elephant in the room as far as nursing care goes. I'm a neonatal intensive care nurse, and our assignments and acuity are often very high. And Santina, when you talked about how the mom in your case study felt judged and that nurses were scoring the baby differently, I think that is a very valid thing that I just observed based on the overall stress of the nurse within an assignment, whether she is able to devote the time for eat, sleep, and console if the parent can't be there. She may be desperate to reach for a PRN of something to try to just maintain her assignment. I often see from caregiver to caregiver. I just wanted to put that out there. It is a factor.
Yeah, certainly. And Eliza, next week we'll talk more about sleep consult and how we can be successful. Certainly the NICU is not the right environment. And we try to, when there's no medical concerns, to have these babies cared for. in other areas where it's easier for parents to stay all the time. This being said, even in these areas, as we saw with the second case, moms may not be able to be there, or mom may be incarcerated, and nursing ratios can play a role. So it's always better when you can have caregivers there. But I think one of the things that maybe we could be doing better or is really having anticipatory guidance during pregnancy, figuring out what's going to be possible. Because, recently with a mom that was incarcerated, so we know this mom was not going to be able to be there. But grandma, then showed up, knew the baby was going to need to have care. And this baby was in the NICU for other medical reason, and this baby did extremely well. But we had a good plan in place where we knew mom was not going to be here because she's in jail and had to return to jail within, very short few hours of delivery. But grandma was aware of the need. This was great work from our obstetrician colleagues, really, and that led to great success. It's not always possible. Yeah.
So can I jump in? This is
Yeah.
a hot topic. So the VNPC has a work group on this. It's eliminating bias in dyad care. And one of the things that we talk about all the time is that the discharge planning and going home really needs to start before the baby is born. So working along the continuum with the OB and the inpatient providers, and then the pediatrician mom's treatment team, and really thinking about what that postpartum period is going to look like. Your child, you will be in the hospital probably for at least 5 days while your baby is monitored. And then there are going to be these follow-up appointments for you and for the baby. And I think right now we're all doing the best we can, but we're very siloed. So part of what we're hoping to do is really work across all of those different fields so we can come up with a good plan before the baby even gets here, because sometimes it feels like we're scrambling afterwards, and the families don't know that they're going to be in the hospital for 5 days, or that the baby's going to be in the hospital for at least 5 days, and then all the follow-up appointments that they'll need afterwards. So we know that we are aware this is a problem, and we just all need to work together to figure out how to solve this.
Yeah. And it doesn't work all the time, but I do think that's going to help if we can have, because there are other family members that can help, using our cuddlers as much as we can. But it's a tricky problem, and certainly the NICU is with the acuity is not a great environment as well. But yeah.
I attended I think it was maybe the Vanna conference, and we had a speaker that spoke about this from West Virginia, and they took this old labor and delivery unit that was no longer used, and they set up basically a unit for these babies that was totally geared towards them and their caregivers, and they had special staff, trained staff members in a very quiet environment, and they really had great outcomes, and they didn't have to use so much a medicinal approach, and it would be great if we had some cordoned off area that was kind of like our isolation rooms a little more, just
which would be great. I believe it's in Huntington, West Virginia. They have a place called Lily's House, and and it's set up like it's offsite. There's medical staff that are there, but each room is set up like a nursery. It doesn't look like a hospital room, and so it's very welcoming. Everybody has their own room, and the families or the caregivers can really settle in with the babies.
Yeah, I think there's other centers that have higher volume than we do that are setting up these units. But in Canada, they have similar system. It really works well. But yeah.
The other nice thing about that type of environment is that I always describe to families that, we're we're more like mommy deer than we think. And you see the babies kind of jumping around in the field next to their mom, and then she hears something and startles, and then they kind of do the same thing, but they have no idea why. And so I think the more comfortable that the parents feel, the more comfortable the babies are, and the less other kinds of treatments they need. And so I think that's hugely important. The physical environment, the emotional environment, the spiritual, all of the supports that we can give them helps this go more smoothly.
Yes.
And going back to Dr. Fairchild's initial question there, I figured this would be a good time. I just posted it in the chat, but there is a link to the DEA training I mentioned at the beginning, and in our session there we addressed postpartum depression, and then additionally there's some really helpful it's a really helpful session on motivational interviewing as well that's tangential to this. And then like the work group that Dr. Holland mentioned, there's a addressing stigma component to this that we did with the UVA psychiatry department. So we ran an entire session with Dr. Jennifer Payne, actually an entire series on postpartum depression earlier this year. Maybe some of you were at it, but that topic that's free and available in the chat, that's you can still get CME credit for, again, for free as a Virginia prescriber, was a broader view, but Dr. Payne's a excellent resource on postpartum depression. So I would suggest checking that out if you'd like a deeper dive. I think we still have 3 or 4 more minutes here for further questions or any observations. And additionally, I mean, again, this isn't grand rounds with white coats, so I've heard mention of a lot of excellent resources. So if you have something, feel free to post it in the chat, maybe some of these specific places or some of these work groups as well.
I was wondering if anyone on the call has any insight or comments on reporting NOWS in Virginia. Are you reporting babies that are meeting the diagnosis criteria, or only those that are on medication? I was just curious what your process is, where you are, if anybody has any comment. Yeah, thanks, Eliza. Sounds like a great place.
Yeah, I was just wondering, how many end up going home and then not, and we miss it. Does that happen often?
It does happen some. Santina, I don't know if you want to.
No, go ahead.
It definitely happens some. Like, we can only monitor the children that we know about who we know were exposed. And if we're not testing everyone, then certainly there are some babies who are going to slip through the cracks. And occasionally they come back in looking like a septic baby, maybe a week later, that they're very fussy, they're not feeding well, they might have fevers. We have picked up a few that way. Even when we do monitor and then we send them home after 5 days and they're doing great, there's always the risk that they're going to come back with worsening withdrawal symptoms, just depending on what mom was taking. So kind of the short answer is we do the best that we can with the information that we have, but we also, as providers, seeing these babies within the first couple of weeks of life, we have to have a high index of suspicion for symptoms that could be withdrawal that would need to be treated. Does that answer your question?
I see a question from Amber Purdy about the Virginia mandate to report these babies. Is that okay? So let me read the question again. So testing, it should be, you should have a systematic approach to testing, so that it's not biased. There's no mandate for testing. The mandate is to report babies that have NOWS by definition, and that's whether or not you require medication. But this testing approach, you know, for the mothers and the babies should just be standardized at your center. So you just don't test this mom because she lives here or because she looks like that. So basically testing is recommended for moms that have known exposures or be that symptoms consistent with withdrawal symptoms. It just needs to be standardized so that everybody is tested for the same reasons. And this may be variable by centers, but it should be something that's standardized at your center.
So we are right here at 5 o'clock. We started at 4 o'clock, so that is a perfect time there to close things out. I will say be on the lookout for the recording of this session, the CME info, and then maybe a few resources. We'll possibly have a PDF of the slides to send out as well, but the slides will be present in the recording. One thing I would like everyone to note and not to leave hanging, I do like Dr. Zanelli's question about reporting infrastructure. That's such a critical component. So maybe think about, if you're going to come back to session 2, on how your organization has this reporting infrastructure, because that's part of the team effort for addressing this. So everyone, we're looking forward to seeing you for session 2. That's next week, same Zoom link, same time with the same panelist. So thanks everyone for joining us here at the Division of Outreach Echo. I'll leave the meeting going for about 30 seconds here, because I think we need to say thanks to our panelists today, particularly Dr. Zanelli, who did a great job of leading the discussion, and then Dr. Kellums and Dr. Holland, who supported. And then thanks also for some great questions and great participation today. All right.
Thank you. Bye,
Great.
everyone.
Thank you guys.